हेलो, हम तो स्टार्टिंग खाली कर दो, हम तो करेंगे, थोड़ा सा स्टार्ट कर दो, वेलकम कर दो तो अच्छा लगेगा ना, ऐसे ठीक है। हाँ, क्या हुआ? बाद में 1 घंटा कुछ नहीं करो, 1 घंटा बाद हमने पार्टिसिपेट करते हैं।
Only 14 participants, so we should wait a bit, I think.
Yeah, let us wait for at least.
Atima De. Atima De.
Atima, yes, Atima has joined.
Meenakshi is there. Yeah.
All the, I mean, speakers are there. I don't see Archana. She is not here.
तो आज के सेशन में उसका नहीं था दीदी, उसने कॉल किया था मेरे को, तो आज के सेशन में नहीं था। मैंने कहा कि नेक्स्ट सेशन में तुम ले लेना मेरी जगह फिर।
इस बार तुम ले रहे हो?
हाँ, 6 का नाम भेजा था, आज के सेशन में उसका नहीं था। अभी उसका कॉल आया था, पिछली बार में था, और आज अतिमा दी, मीनाक्षी मेरा और आपका है। नेक्स्ट टाइम मेरे चाहे आपकी जगह पर ले लेगी शिव अगली बार।
तुम क्या बोल रहे हो? Hi Atima.
Hi Sumandi.
How are you?
Fine. तो स्टार्ट करें हम लोग क्या? बहुत लोग तो ज्वाइन कर लिए।
पार्टिसिपेंट
18 सबको पार्टिसिपेट
थोड़ा सा 20-22 हो जाने तो फिर कर ले।
क्योंकि बहुत लोग फोन कर रहे थे ना कि रजिस्ट्रेशन आज का क्लोज हो गया है, 100+ पार्टिसिपेंट्स हो गए हैं।
ऐसे हमें तो 14 ही दिख रहा है। अच्छा, हम तो जूम लिंक दे। अच्छा, ठीक बोल रही हो। वो हु इज द, ठीक बोल रही हो तुम, इसलिए ना कि हमें तो वही दिखेगा जो कि फैकल्टी है, बाकी का तो हमें नहीं दिखेगा, इसमें तो आएंगे ही नहीं बोलो ना।
हाँ, तो वो ये लोग बहुत लोग फोन किए थे कि रजिस्ट्रेशन इज क्लोज शो कर रहा है बिकॉज पार्टिसिपेंट्स आर 100+। तो हम उन लोग को बोले कि तुम लोग 24th का आज ही रजिस्ट्रेशन करा लो।
24th को भी है नेक्स्ट।
So now we are going to start the sessions. Good evening, everyone. On behalf of Ranchi Obstetric and Gynecological Society, we are here for respectful abortion care sessions, and it is recommended by FOXY in collaboration to WHO, and it is mandatory to everyone. Everyone has to fill the pre-test and post-test questionnaire. Then only they will be getting eligible for the certification of the respectful abortion care. So here the sessions are very basic about the how we have to interact with the woman, and how we have to provide the abortion care with dignity, and what are the safe procedure, what is the new amendment of the act, and post-abortal care as well. So in short, we will today's session will be taken by the Dr. Suman Sinha, who is president of Ranchi Obstetric and Gynecological Society. Dr. Atima Bharti, she is working as associate professor in Rajendra Institute of Medical Sciences. And Dr. Meenakshi, she is having a private hospital for maternity and child care. And myself, Dr. Kiran Trivedi, serving as associate professor in Rajendra Institute of Medical Sciences and holding the post of secretary in Ranchi Obstetric and Gynecological Society. With these words, I want to start the session. And the first session goes to Dr. Suman Sinha, who is our president. So I invite her for proceed further. Sumandi, please start the.
Thank you very much, Dr. Kiran, and a very good evening to one and all, and namaskar to everyone, all the delegates and the faculties and the dignitaries who have joined today. My topic will be on the RAC amendment. As we all know that the RAC Act was first done in 1971, and then it was first time amended in 2003. And after that, the amendment was done in 2021, that was March 16. And further, it was enacted now from the 24th of September. So what it is and how to go about it, we'll learn through the slides which has been provided to us by FOXI and WHO jointly. So let me open this slide. Give me permission to open my PPT. Can you see my slides?
Yeah.
Okay, thank you. Just a minute. Yes. So the first session is known as Module 1, which consists of Medical Termination of Pregnancy Amendment 2021. As I have already explained that this act was formed in 1971 to safeguard our females from unsafe abortions, which was amended in 2003. And the next and the last amendment, which has taken place recently in 2021, March 16th, and which is enacted since 24th September. What it is, we should know by the coming slides. So it is all for the respectful abortion care, which is joint association of FOXI and WHO. So in the following slides, we will take a closer look at what are the new laws and what are the changes in rules. Laws we all know because we all have studied. Since 1971, this act is there, so we all know. But there has been recently new changes in favor of our women to save their lives, to decrease the maternal mortality rate. So, what was unsafe abortion? Previous to this, unsafe abortions in India led to mortality, morbidity, and harmed the women's and girls' full participation, hampered women and girls' full participation in the society. As we all know, 8% of maternal deaths every year occurs due to unsafe abortion, and it is also third leading cause of maternal mortality. You'll be surprised to know that nearly 2 out of 3 of the abortions were performed in deemed unsafe situation. And nearly half of pregnancy-related deaths are in women and girls under 24 years because they are very young and they don't like to disclose it to their family, the parents, and they used to go for unsafe abortion and they've suffered grievous injury or even death. So, when is abortion considered safe? According to WHO, when it is done by the appropriate method and when it is done by the trained persons. So if any one of the situation is permitted, like if it is done by the trained persons, but the method is not appropriate, then also it is not safe. Or if it is done by appropriate method, but the person is not trained, then also it is not safe. So for being it safe, it should be done by a trained person and it should be done by the appropriate methods, which is recommended by our FOXI and also by the WHO. So this medical termination pregnancy was amended in 2021, March 16, for safe and comprehensive care to our women, which is mandated by law. So what has been changes in the previous MTP Act? Earlier, as we all know, there was requirement of opinion of one provider for MTP up to 12 weeks. But now, thing has been changed. Now, the requirement of the opinion of one registered medical practitioner is required in the termination of pregnancy up to 20 weeks. So it is extended from 12 weeks to 20 weeks, and the requirement of 2 registered medical practitioner for MTP between above 20 to 24 weeks is in the new act, whereas previously 2 providers were required for termination even between more than 12 weeks and less than 20 weeks. So for 12 to 20 weeks also, we needed opinion of two medical registered medical practitioner. Nowadays, up till 20 weeks, it can be done by one RMP, and after 20 weeks and between 20 to 24 weeks, opinion of two is required. So what is the benefit of this? Benefit is this, that there can be increase in the number of facilities who are providers for providing this respectful abortion care, like in the PSCs, public health centers, for services up to 20 weeks, which is beneficiary for our women. So now, what are the modifications for the vulnerable group of women? Who are the vulnerable group of women? We should understand. Previously, in the MTP Act was that it was permissible only for 20 weeks. MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the women. But nowadays, this age has been, upper gestational limit has been extended from 20 weeks to 24 weeks for the special and the vulnerable categories of women. And further, there has been enhancement for birth defects not compatible with life or medical board consensus. So what is this enhancement? If a woman is carrying a baby which is suffering from severe birth defects or which is not compatible with life after birth, then there is no limit of gestational age. It can be terminated any time. This has been the changes in the 2021 amendment. So what is the benefit of this? It will increase access for all the vulnerable women to the safe and legal abortion services. It is defined by rules committee. Who are these victims? They are the victims of rape, incest, our minor girl child who has suffered this. But mind you, this is not after 20 weeks, it is not for contraceptive failure. This we have to understand. If patient has unwanted pregnancy due to contraceptive failure, it doesn't come into this category. So now what modification has been done for birth defects and congenital anomalies? Previous Act says the Act had provision for termination of such pregnancies only up to 20 weeks when there was birth defect in the fetus or fetus suffered from severe congenital anomalies. We had the permission to terminate only up to 20 weeks. Nowadays, there is no limit. Upper gestation limit does not apply in those cases of pregnancies where there is substantial fetal anomalies diagnosed by a medical board. But there is one clause for termination of pregnancy due to congenital anomaly or fetal malformation after 20 weeks, we have to take permission of the board. So what is this potential outcome? What is the benefit of this amendment in the Act? It will increase in access to safe and legal abortion services who often seek service late beyond legal limit for termination pregnancy with substantial fetal anomalies diagnosed late, thus reducing unsafe abortion. What will happen? Earlier, it was not permissible more than 20 weeks. And as we all know, in our setup, we come to diagnose these severe congenital anomalies in late pregnancies. And then they did not had any access for the termination of pregnancy. Then they used to go to the coax or they used to undergo unsafe abortion and they used to risk their life. So it has been for the benefit of our women who had a fetal pregnancy with fetal anomalies and they want to terminate the pregnancy, because you know NIPT and all, it is done after 16 weeks, around after 16 weeks it is done. Even the amniocentesis also is done later in the pregnancy. And so if our government did not allow this, then they had no option. They had to go to get their pregnancy terminated by unsafe methods, and they used to risk their life. So it is for the benefit of our women. Now, what also has been done modifications in the marital status. Earlier in the act was that this contraceptive failure, MTP for women due to contraceptive failure was allowed only to the married woman or her husband. But nowadays, condition of failure of contraceptive to be extended to any woman, either she is married or not married, and even it extends to her partner. So what will be the benefit of this? It will increase again access to safe and legal abortion for any woman, either married or not married, irrespective of this marriage age, especially with upcoming change in the legal age of marriage. As we all know, now the legal age of marriage has extended up till after 18 years. Now it's around 18 years. Just a minute. An important advancement of increasing access to safe abortion. This all has been done to help our women to undergo safe abortion. Now, insertion of new clause for strengthening privacy. One thing is very important. Now we have to maintain the privacy of the patient. We cannot disclose this to anywhere, even in our hospital setup. So how can we do this? It is very important. I'm going to tell you. Earlier in the previous act, the Medical Termination of Pregnancy Regulation 2003 mentioned that information should not be disclosed except under authority of law. Even in previous act of 2003, it was that it should not be, the name of the patient should not be disclosed. Nowadays, a strict law has come. What is this law? Name and other particulars of woman whose pregnancy has to be terminated shall not be revealed except to a person authorized by any law for the time being in force. It means what? Patient will come in the hospital, she will get a registration number. Now, when you will maintain two registers. In one register, you will write her name and register registration number. Now, when you will make a BST or a card where you will write the OT note, you will only write the registration number, not her name, never. And the register where you have written her name and registration number together, you have to keep under lock and key. Why? Because her identity has not to be revealed at any cost. And if anything suppose goes wrong, the case has not been managed well, or there's some issues has been with the termination, you have faced some difficulty, then law may ask you to provide all the papers. Then you have the right to open your drawer where you have kept the register and you can reveal the name. So otherwise you don't have to reveal the name. And why? What is the benefit of this? The benefit, let us see what it is. It says that it increases the privacy and confidentiality of abortion seekers. So you have to respect our topic of today's discussion is respectful abortion care. How can you respect your woman? Because nobody wants to get disclosed about her treatment, about her disease, about what she wanted to hide from the society, and it is being disclosed in the hospital. No woman wants. So it is done for their privacy and confidentiality. Then what will happen? It will be increased demand for safe abortion. These women will come to our hospital, to come to your clinics, because they know that their rights and dignity is being maintained, and say they will be provided with respectful, bias-free services. And then you should give time to them, counsel them regarding contraception advice, so that they do not fall prey to this MTP again. If they will take proper contraception, there will be no requirement of this MTP. So you give time to your patient. So what are the silent features of MTP 2021? We have to prioritize confidentiality and safety. So look, they're telling repeatedly, we have to maintain the confidentiality of our patient. So name and other particulars of any woman seeking abortion should be confidential, should be kept under lock and key, except to a person authorized by law. So if there is a need of a if they need to disclose the confidentiality of the patient, it is only the person who has been appointed by the law. And the ground of failure of contraceptive has been extended, and this is not only for the woman but also for partner. Maybe contraceptive failure has been occurred due to her partner wrongly used medicine. So now we are going to understand 3 points that is very important. Number 1 is, what is special or vulnerable category of women who are eligible for extended gestational period of termination pregnancy from 20 to 24 weeks. Who are these women? Number 2, the norms. What are the norms for the RMPs whose opinion is required for termination pregnancy at different gestational age? And what are the powers and functions of medical board? So one by one, so 1, 2, 3, we are going to cover quickly. So the special category of women eligible for MTP between 20 and 24 weeks. Who are those? Number 1 is survivors of sexual assault, survivors of rape, survivors of incest. Number 2, women with pregnancy in humanitarian settings. What are the humanitarian settings? When pregnancy has occurred in a disaster, when pregnancy has occurred in an emergency situations, as many women wanted termination of pregnancy during the COVID period. They became pregnant and they had the opinion from somewhere, they got the opinion from somewhere that this baby is going to suffer from severe congenital anomaly, and they wanted termination of pregnancy. It can be taken here, or when there is a situation like bomb blast or explosion of the factory explosion, that which occurred long back in Bhopal tragedy, you all might be knowing. In those situations, if women is pregnant and she wants termination of pregnancy, now it is legal. Now, number 3, change of the marital status during the ongoing pregnancy. Suppose patient has become pregnant and she is divorced, or she has become widowed. So she has the right of getting her pregnancy terminated if she wants. Now, if women with physical disabilities, if a woman has become pregnant and she is suffering from physical disabilities, then physical disabilities also has a criteria. It has to be under the Disability Act. So this has to be first checked, and then you can terminate the pregnancy. We have to understand the Disability Act criteria. Now, if the woman is mentally retarded, or if the child is a minor, then she is liable for termination of pregnancy beyond 20 weeks. Okay, and now even in cases of fetal malformation that has substantial risk of being incompatible with life, or if the child was born with it would suffer from severe physical and mental abnormalities to be seriously handicapped, then also the women can get her pregnancy terminated. So these are the vulnerable category of women, and she has the legal right of MTP. Now, what are the norms of RMP? So number 1 norm is all RMP has to have MBBS degree. They should be MBBS first, and number 2 is they can be after MBBS they can have degree or they cannot have degree, but MBBS is a must. So if a medical practitioner is an MBBS doctor and has done 25 cases of MTP, assisted 25 cases of MTP, and 5 of them has been done independently in a hospital, then he or she has the right to do MTP, and that they had right to do medical termination of pregnancy by law. Or this MBBS doctor, if he has 6-month house surgeonship training in obstetric and gynecology, then he or she has the right to do medical termination of pregnancy. Or MBBS doctor who has a postgraduate degree or diploma in obs and gynae, he has the right to do medical termination of pregnancy. Or MBBS doctor who has at least 1 year experience in obstetric and gynecology department, he has also the right to terminate pregnancy. These all has been simplified to help our women to undergo safe abortion care. So now the second norms of RMP is now one more amendment has been done in this 2021, which was not earlier. Why? Because now this medical termination of pregnancy has been approved by the law. Earlier, it was medical termination pregnancy was not approved by the law. Now it is approved by the law, and that is for termination up to 9 weeks with medical methods. We'll understand, and after that also we are going to understand later in the following slides. This is known as the additional category of provider has been added. We all are the providers. So who can do this medical termination of pregnancy? All the RMP means all the registered medical practitioner who is a MBBS. MBBS is a must with experience in practice of obstetric and gynecology, not degree of obstetric and gynecology. See here, has the experience in the practice of obstetric and gynecology at any hospital for 3 months. The timing for up till 9 weeks has been reduced, not 6 months. It is only 3 months. Or this MBBS doctor has a training with performance of 10 cases of MTB by medical method of abortion, but under supervision of a RMP in a hospital, which is established or maintained by government or approved by government. So up till 20 weeks of gestation, 1 RMP opinion is required. Up to from 20 to 24 weeks of gestation, 2 RMP opinion is required, and beyond 24 weeks, medical board opinion is required. So now we are going to understand the norms for the RMP, that is for the MBBS doctor, whose opinion is required for termination of pregnancy at different gestational age. So till 9 weeks, experience and training required for RMP. See how the paradigm is being shifted. So up to 9 weeks, experience, this MBBS doctor should have experience in any hospital for 3 months in the practice of obstetric and gynae, or has independently performed 10 cases of MTP by medical method of abortion under supervision of a RMP in a hospital established or maintained by government or approved by government. And the training institute has to be approved by the government. Number 2, a practitioner who is MBBS and has assisted RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. Number 3, a practitioner who holds a postgraduate degree or diploma in obstetric and gynecology. Number 4, a practitioner who has completed 6 months of house surgeonship in obs and gynae. And number 5, a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetric and gynecology. Matlab ki more than 1 year, and here all we are dealing up till 9 weeks. So only opinion of 1 RMP is required. Now the norms for the RMP whose opinion is required for termination of pregnancy at different gestational age. Now till 12 weeks, it is also almost same. See, and when we will go further after 12 weeks, what we'll see just a change. Number 1. Here also, an MBBS doctor who has assisted RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. Or a practitioner who holds postgraduate degree or diploma in obstetric and gynae. It has taken now the 2nd place. And 3rd is a practitioner who has completed 6 months of house job in gynae. Or number 4, a practitioner who has worked in obs and gynae department for more than 1 year. But here, up till here, 1 RMP is required. This is up till 12 weeks. Now see a change. From 12 to 20 weeks, experience training requirement for RMP MBBS doctor. Here, from 2nd position, the MBBS doctor holding a PG degree, now comes the 1st position from 12 to 20 weeks. We have to take care. We all are gynecologists. For us, it is not a big issue, but those doctors who are not a gynecologist and practicing gynae and doing MTP, for them it is very important. If they don't have a degree and the pregnancy is after beyond 12 weeks, please don't handle this case. Why? Because number 1st position is a practitioner who holds a postgraduate degree or diploma in gynae. It takes the 1st place. 2nd is if you have a house job MBBS doctor who has a house job in 6 months of house job in obstetric and gynae, they also can do it. And number third is if 1 year in the practice of obstetric and gynae. So first is the PG degree holder, second 6 months. So there will be, this is all legal, you know. Now there will be no case if an MBBS doctor does a MTP beyond 12 weeks and has 6 months house job. It is they are legally, they have the right to do medical termination of pregnancy, and up till 20 weeks only one opinion of RMP is required. Now beyond this, beyond 20 to 24, so it has been, I mean, बहुत liberal कर दिया गया है इसको. All MBBS doctor who has a postgraduate degree or who has 6 months experience in house job, who has done house job in obstetric gynae, or who has 1 year experience in obstetric gynae, can perform MTP up till 24 weeks. Though beyond 20 weeks until 24 weeks, two RMP's opinion is required. Now beyond 24 weeks, what will happen? Beyond 24 weeks, experience and training requirement for this MBBS doctor, a practice number 1 position again comes the doctor who holds a postgraduate degree or diploma in obs and gynae, or this practitioner who has worked 1 year in the obstetric and gynae department. Now they cannot terminate the pregnancy beyond 24 weeks without the signal, without the opinion from the medical board. Medical board has the power to give them the opinion. The opinion of medical board is required for the termination of procedure when advised by the medical board is carried out with all safety precaution along with appropriate counseling and at an approved place. So, how this medical board is formed? It requires a gynecologist, it requires a pediatrician, and it requires a radiologist. If you don't have a radiologist, a sonologist will do. Now, what are the powers of these medical boards? It will allow or deny. It has the power to allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for the woman. They have to see that if we are terminating the pregnancy beyond 24 weeks, so our woman has to be safe. They will study this. They will take opinion for all three of them, will take joint opinion. And if required, they can take opinion of some more doctors at that for that gestational age and whether the fetal malformation has substantial risk of being incompatible with life or not, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped or not. They will take a joint decision and then they will give the opinion within 3 days. They have to give the opinion, and they can co-opt other specialists also in the board and ask for any additional. They will like to do some additional investigation, how much you have done. Even after that, they will like the patient to undergo some additional investigation, and if required for deciding on the termination of pregnancy, and then they can give the opinion. So FOXI with ministry guidance and WHO support as part of RAC can operationalize and host medical board information on website. FOXI, there is one note now that FOXI with help of our ministry and WHO, they will like to put on the website who are the boards for which state. It means that board information of website. It is in the process, it has not been completed yet. So what will be the functions of board? To examine the woman and her reports, whatever report you have provided, the medical board is going to examine, and who would approach for medical termination of pregnancy. For the woman who is approaching to the board for medical termination of pregnancy, it will provide the opinion. It will provide the opinion of medical board in the form D with regard to the termination of pregnancy or rejection. It will allow the termination of pregnancy or rejection of the request for termination of pregnancy. In that form D will be written, and that too within 3 days of receiving the request for medical termination of pregnancy. They cannot delay. And to ensure that the termination procedure, when advised by the medical board, if has given not to undergo medical termination of pregnancy, should be carried out with all safety precautions along with appropriate counseling within 5 days. The board will give their opinion in 3 days, and the provider will do the termination within 5 days of the receipt of the nod from the medical board. So FOXI has an important role to play in ensuring there are functional medical board in every state. FOXI will take important part in making the medical board in every state, as is stated in MTP Amendment 2021. So every state should have a medical board. So now center does not have any role in this. Every state is now compatible to give to form a medical board and give the opinion. So, dear friends, thank you for listening to this very important talk. And I hope before joining this, you have done the pre-test, and now after all the lectures, you have to undergo the post-test and you give us the feedback, and then you will be provided with certificates after you complete the post-test. So thank you very much for your listening.
Hi, Kiran. Good evening, everyone. Can I just talk for 2 minutes, please?
Yes, sir. Good evening.
Yes, sir.
A huge congratulations to the Ranchi Society for organizing this, and compliments to the leadership team who has led this entire program to be where we are today. And I do understand that today there were 100 registrations, and only about 47 have joined in, which is rather, they blocked the seat and they did not join. So others who wanted to join also couldn't join. But I'm really happy that you had some foresight and forethought, and you planned another session on the 24th of April. So I'm hoping that on that day, the remaining people can also join in and complete this entire process. At the end of 24th April, we will also be sharing all the slides with you, each and every participant here, so that you have it in your system and can refer to it at any point in time. Bottom line is that the rules and the amendments have been made absolutely pro-women, for the women of our country. And India is perhaps the only country who has had an MTP law for almost 40-45 years. And many countries are even struggling today to even get a law in place. And from those days, of abortion to today, when we are talking of respectful abortion, we have come a long way. And each one of you, with my humble request, please continue the way you have been functioning and supporting the women of our country, because that is the most important task that each one of us has over here to take this whole process forward. And I must really thank our beloved President, FOXI President, Dr. Shanta Kumari, who has been at the forefront of making sure this partnership with WHO took place, with Government of India took place, and also a special honorarium was negotiated in the budget for the society and for all the trainers. So, that also will be coming to the society directly and to the trainers who are here. It's good to see Atima here, and yes, Suman did a fabulous job. Thank you very much. And all the very best. Continue with the lovely program that you're already having. And in case there is anything else that you require from us, please do not forget to send us an email, and the backend team will completely support each one of you. Ranchi is is a place very close to my heart.
Oh, thank you.
And I mean, I've got to know all of you now through various emails, but I have been coming to Ranchi for the last 20 years, on and off couple of times.
Since I am also an EMOC trainer, so I had met you during that training period, and you had come here to Ranchi.
Yes, Atima, I remember you. And it was
and today last moment I was getting so many calls from the members that we are not able to register because we are getting a message that registration is closed. But
We have sensitized the members since today,
but they didn't attend.
No, that is, see, that is what I said in the chat box for everybody to know. The registration was for 100 participants because we knew you're having two batches.
Only 46 have joined.
People have registered.
And they have not joined.
Yes.
But they have
That is not fair. That is not fair.
And I asked them, sir, I asked them that, I sent them the link for 24th and I asked them to register today itself.
Yeah, today itself, please do that because as I can see,
only one has registered.
Only one registration is there. I'm hoping people who have not registered can do so immediately. What I will do is, let me see the date chart. In case you have more than 100 registrations, even for the 24th, just let me know. And if anybody who's registering and gets the same message on that day, let me know. I will try to
replace
one more time slot.
Yeah, or more time slot, or I will pull them all into another society time slot so that they can join any of the society, because it's the common FOXY program. And as long as they get the knowledge base, it should not be an issue. And since Ranchi Society has already done the job, I think it is going to be to the credit of Ranchi Society in any case that you have trained most of your members over there. At the end of the session, my colleague here, I think Sriman is here. He will post the post-test and chat, the feedback in the chat box. Please click on that link so that you immediately can, within the next 5 minutes, submit that post-test and feedback so that your certificates can be issued automatically by the system and we don't have any role to play over there. Yeah. So with those few words, all the very best. Please continue your good job and all the very best. Namaskar and have a lovely evening, each one of you, at the end of the session. I will have to leave now to get into another program, but all the very best to each one of you.
Thank you, sir.
Thank you, sir. Thank you for being here.
Bye-bye.
Bye.
Please continue. Yeah.
Okay. So next program, Kiran.
Next session is of mine. So I'm going to share the screen. So here I'm getting the I cannot share the screen.
I made you co-host, madam. You can try now.
So it is visible to everyone?
No.
No, Kiran.
It's not visible.
No.
No, not visible.
What is the topic I can share for you?
Our topic is on
So
technique.
second one.
What
It
will
is
do?
on technique. It is on technique, Di.
Okay. Can I share for you?
So
Yes.
I can share it.
If you can.
अब आया क्या?
नहीं आया किरण.
मॉड्यूल
रुकिए एक मिनट.
नहीं आएगा तो मैं तो तुम्हारे लिए कर दूंगी. ठीक है.
कर दीजिए. कर दीजिए.
अच्छा.
हाँ कर दीजिए.
Just a minute. तुम्हारा टेक्निक है ना? This is again module. Okay. No. हाँ. Just a minute. शेयर करना पड़ेगा ना मुझे पहले तो.
रुकिए दीदी कर रहे हो.
हाँ ठीक है, करो हम एक्चुअली आउट हो गए हैं शायद कैसे भी. जूम में जाना पड़ेगा.
You are sharing screen. आ गया?
हाँ आ गया.
So my topic is abortion, how to provide the abortion. So about techniques I have to say today, and next session is about the procedure, what we are. ये आगे नहीं बढ़ रहा है लेकिन मेरा वाला.
Madam, you are in the last slide. Madam, you have to click on this enable editing button.
पीछे जाओ.
on the top.
Okay.
कर पा रही हो?
Click on that enable editing button, madam.
ठीक है, स्टार्ट करो.
अब आ रहा है. So today I am going to discuss about the techniques
Madam, it's
of
not
the
full screen,
safe
madam.
abortion.
Kiran, madam.
Huh?
It's not full screen, madam. You have to
बोलिए.
click on this enable editing button, madam. Click on this enable editing button.
ऊपर में
This
enable
is on
editing
the top.
व्हाइट कलर का किरण. देखो enable editing वहां डालो.
हाँ, enable editing तो screen sharing है, enable editing तो नहीं
कर
है.
दिया? क्लिक करो उसको फिर.
ऊपर में है किरण एनेबल एडिटिंग,
लिखा हुआ है.
ऊपर में लिखा हुआ है.
लेकिन मेरे में नहीं है दीदी.
हाँ होगा
पीछे
किरण, जस्ट ऊपर में.
Stop video, mute, display, setting,
तो
show
white
taskbar.
box में है दीदी.
व्हाइट कलर का लिखा हुआ है.
व्हाइट कलर का ब्लॉक बना हुआ है एनेबल एडिटिंग.
तो tell me what you want to do के नीचे.
इसमें नहीं आ रहा है पर
कवर हो गया होगा.
आप कीजिए तो शेयर दीदी,
आप करें तुम
या जो टेक्निकल पर्सन है वो कर सकता है.
तुम हटोगे तो हम कर देंगे. तुम निकलो.
स्टॉप शेयर कर दे.
हाँ स्टॉप शेयर. हाँ सुमन दी आप कर दीजिए इसका.
हाँ हाँ कर रहे हैं.
करिए.
हाँ आ गया
ना. अब फुल स्क्रीन कर रहे हैं.
बढ़ाई.
हाँ ठीक है, दिख रहा है. कैन यू सी?
हाँ दिख रहा है.
It's visible दीदी. It's visible.
Okay.
So now I have to proceed further with module 2, that is safe abortion updates in technology. So this is the module which is saying us about the respectful abortion care joint venture of FOXY and WHO. Next. Now in this session, we have to see what are the existing guidelines for abortion care, pre-abortion assessment of the patients, medical methods of abortion, and what is the surgical methods of abortion. So these are the manuals which are available. WHO Global Guidelines on Safe Abortion. These are the manuals you can see here, and you can find out on net also. Next. Next. So now next.
Okay.
So mother MOHFW National Guidelines on Safe Abortion has come in practice since 24th of September 2021, which is already discussed. What are the recent amendments in the law of MTP? So this, after this historic change, we are more able to provide the safe abortion services to our women. Next. So all guidelines have 3 key areas in management of abortion safely. First is pre-abortion care. Second is abortion care methods. And third one is aftercare or follow-up, including post-abortion, abortal contraception and counseling. So whenever the woman comes to us, first of all, we have to take the medical history and do the physical examination of the woman, including general as well as pelvic examination. If anything essential in medical history, we can prescribe lab investigation accordingly. Otherwise, ABO-RH is mandatory before performing the abortion, because if she is RH negative, we have to give anti-D prophylaxis. And then we will discuss the contraceptive options to the woman, and we will help the woman in the decision-making of the abortion technique. If a woman chooses to have an abortion, she should be allowed to choose from among the available methods that are appropriate for her based on duration of pregnancy and her medical condition. So how we have to do the pre-abortion assessment and counseling? So what are the components of pre-abortion assessment for women seeking first trimester abortion? First point is detailed history taking about LMP, previous parity, what are the associated medical condition, any drugs she is taking, any special precaution, or any medical history she wants to inform us. Then comes the general physical and pelvic examination. In general physical examination, we have to take care about anemia. So level of hemoglobin and pallor is very important. And pelvic examination is also done, which is going to be elaborated in next slides, where what is the importance of pelvic examination. We will discuss about that. And laboratory investigation and the other investigation, if required, we have to prescribe. Then lastly, we are telling the options. What are the medical methods? What are the surgical methods? According to her gestational age and medical condition, what are the procedure available, and what is its pros and cons? We should inform them. Now here we can see that gestational age is determined by LMP or physical examination. Or usually the LMP estimated gestational age and physical examination correspond to each other. But there are some, if we are going to examine up to 12 weeks, it is a pelvic organ. After 12 weeks, it becomes an abdominal organ, just palpable. And midway between 15 to 16 weeks of pregnancy, it will be midway between symphysis pubis to umbilicus. And after that, up to 20 weeks, it will reach the umbilicus. What are the limitations of dating by the uterine size or physical examination? You can see here that first, the uterine malformations or fibroids may give some confusion about the assessment, or there might be multiple gestation, there might be marked uterine retroversion, obesity, or molar pregnancy. A uterus can appear smaller than expected, may indicate the woman is not pregnant, the date is not accurate, or she might have ectopic or abnormal intrauterine pregnancy, which is due to spontaneous or missed abortion. Or we may get uterus, which is larger than expected gestational age, which may indicate the inaccurate menstrual dating, multiple gestation, uterine anomalies such as fibroids or molar pregnancy. Next. So pre-abortion investigation. So routine lab investigations are not required, and it is not a prerequisite for abortion services. Tests that may be performed as per individual risk factor on finding of physical examination and detailed medical history taking, as I already told in previous slides. The pregnancy test should be done if there is any confusion about the pregnancy. Hemoglobin or hematocrit for suspected anemia should be done. But RH we should know beforehand, giving either medical method or surgical method, because we have to provide the RH immunoglobulin, which is must for RH negative women. We can go for HIV testing and counseling. STIs screening is usually performed during pelvic examination, and other laboratory tests are indicated, should be done if indicated by medical history, such as kidney and liver function test. Ultrasound, mind it, ultrasound is not necessary unless to diagnose the pregnancy, diagnosis of pregnancy is not certain, or suspecting an ectopic or missed abortion. If the uterine size is less, I already told you, or if there is any doubt due to large size of uterus. If it is not corresponding, we can perform ultrasonography to rule out any missed abortion, spontaneous abortion, or suspicion of ectopic pregnancy. Next. So pre-abortion counseling, we have to ask something. So thoughts about the what is the thought in decision of terminating the pregnancy, and what is the reason for termination. Now some information we have to pass, that early abortion is safe. We have to reassure the patient. Previous one.
Yeah, sorry.
So early abortion is safe. Importance of a trained provider performing the procedure for safety. Available methods for abortion, and risk and warning sign associated with the abortion method. Without contraception, she can get pregnant as soon as 14 days after the abortion, and she can resume her activities, including sexual intercourse. And we should explain these all points to the woman, and any other follow-up care. We have to document something. What? Informed written consent and decision to accept the post-abortal contraception. But it is not necessary that we should perform abortion if the patient is willing to opt for contraception. Even if she is not willing for contraception, we have to provide the abortion services to her. Next. Now, clinical management of abortion. So it can be divided into two, that is less than 12 weeks and more than 12 weeks. Less than 12 weeks, global recommendation is medical methods of abortion, that is mifepristone and misoprostol alone, and surgical method is vacuum aspiration. And more than 12 weeks, again, mifepristone and misoprostol only, and dilatation and evacuation. What is not recommended is dilatation and curettage, because in pregnant uterus, we are doing blunt curate, not the sharp one. Government of India recommendation is medical abortion should be performed up to 9 weeks only. For up to 7 weeks, mifepristone 200 followed by 24 to 48 hours, misoprostol 800 micrograms sublingual, buccal or vaginal route. Whereas for 7 to 9 weeks, mifepristone followed by after 24 to 48 hours, misoprostol 800 sublingual, buccal or vaginal. Next. Now, two type of methods available for abortion for first trimester, that is medical methods and surgical methods. Medical methods, including mifepristone and misoprostol, whereas surgical methods in electrical vacuum aspiration and manual vacuum aspiration, that is MVA. So tablet mifepristone and misoprostol, how it works? First of all, when we give mifepristone, which is an anti-progestin, it inhibits action of progesterone. Then it interferes with the continuation of pregnancy. We all know that mifepristone is going to inhibit the progesterone, which is the essential hormone for continuation of pregnancy. Now, after initial dose of mifepristone followed by misoprostol, a prostaglandin E1 and a low. Misoprostol causes cervical softening, uterine contractions, and expulsion of products of conception. Next. So, protocol for mifepristone and misoprostol. Day 1, mifepristone administration. The dose is 200 milligram mifepristone oral, along with anti-D 50 microgram, which is microgram from Johnson & Johnson, if RH negative woman is there. And day 3 of mifepristone administration, up to 7 weeks, 400 microgram misoprostol, that is 200, 2 tablets, sublingual, buccal, vaginal or oral. And in 7 to 9 weeks, 800, sublingual, buccal, vaginal. In addition to analgesics, if required, antiemetic and contraception. Within day 15, follow-up day, we have to confirm and ensure the completion of the procedure, and we have to offer the contraception if not already done so, because we all know that after 14 days of termination of pregnancy, if she resumes sexual activity, she can get pregnancy. Next. So, characteristic of different routes of misoprostol administration for first trimester abortion. First is oral. Pills are swallowed and recommended up to 7 weeks for first trimester abortion. Side effects include diarrhea, nausea, fever, and chills. Buccal. Pills are placed between the gums and cheek and swallowed after 30 minutes. The chills and fevers are more than the oral. Chills and fevers are more than the vaginal route. Sublingual pills are placed under the tongue and swallowed after 30 minutes. And the fever, chills, diarrhea, vomiting compared to vaginal route are more. And it is the fastest route for onset of action, and highest plasma concentration levels are found. So vaginal pills are placed in the vaginal fornices, deepest portion of vagina, and the woman is instructed to lie down for 30 minutes so that it get absorbed, and pill fragments may be visible, and lowest rate of side effects are found in vaginal route. So here you can see that in buccal one, it is placed by the side of the cheeks, and in sublingual, it is under the tongue. Next. So WHO drug regimes dose schedule for medical abortion. Induced abortion less than 12 weeks, 200 per oral, mifepristone. Then after 24 to 48 hours, misoprostol 800 by buccal per vaginal or sublingual route. And misoprost only, it should be given 800 buccal per vaginal or sublingual. The vaginal bleeding for 2 weeks is normal after medical abortion, and we have to counsel and pass on these informations to the women to whom we are providing the services. Such bleeding can last up to 45 days in rare cases. So provision of medical methods of abortion services. These services should be available at the primary care level with referral system in place for all required higher level care. Additional services may need to be provided to individuals seeking medical abortion, counseling and testing for STDs, that is STIs and HIV, abuse support services, psychological or social services, and other specialist health or medical services. We have also to provide iron tablets for anemia if needed and any necessary pain medications. We have to provide emotional support if she requires. For follow-up care, first is routine follow-up, not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit at 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, and address any medical concerns. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess the success of the abortion. So, routine follow-up is recommended in misoprostol alone or any complication are there or for contraceptive services. So, for follow-up care, we have to assess the woman's recovery and ask for any sign and symptoms of ongoing pregnancy. We have to review any available medical records and referral documents. We have to ask about any symptoms experienced since the procedure, perform a focused physical examination for any complaints, assess the woman's.
Oh, what happened?
Sumandi,
Something got
last हो गया कैसे?
Just a minute, हो जाएगा ठीक. Last हो गया. Okay. कितना बाकी है?
अभी बाकी है दी काफी.
Okay.
नीचे जाइए मैं बताती हूँ.
करते जा रही हूँ.
पास कीजिए. स्लाइड शो.
कर रहे. एक बार वहां पहुंच जाए फिर स्लाइड शो कर देते हैं.
हाँ.
अचानक से बैटरी चला गया.
बस यही पे. हाँ यही. इसके पहले वाला.
इसके पहले वाला.
हाँ.
ये वाला.
बस.
वाला क्या?
So we have to assess the woman's recovery and ask for any signs and symptoms of ongoing pregnancy, review any available medical records and referral documents, ask about any symptoms experienced since the procedure, and perform a focused physical examination for any complaints. We have to assess the woman's fertility goals and need for contraceptive services if not provided earlier. Next. Now, medical methods of abortion summary. So first visit, day 1, what to do? Physical and pelvic examination, confirm the eligibility, that is up to 49 days or 7 weeks. Tablet mifepristone 200 milligram orally should be given along with anti-D if she is Rh negative. Now we have to explain that she has to return for misoprostol administration after 2 days. Contact address and phone number of the facility center where she can go in case of any emergency should be mentioned on the prescription, and record her experience of any side effect of on the MMA card, that is medical method of abortion. 3% of women may expel completely with mifepristone alone, but misoprostol schedule should be completed in every woman. Now, second visit is day 3. What we have to do, give misoprostol 400 sublingual, buccal or vaginal or oral. We have to observe for 4 hours. Analgesic ibuprofen 400 should be provided if she needed. Contraceptive options like condom hormonal method should be discussed. And we have to tell the woman that mean period of bleeding may be 8 to 13 days. Possible side effects are nausea, vomiting, diarrhea, headache, fever, and dizziness. Report in case of excessive bleeding, pain, abdomen, and fever, and report if there is no bleeding for 24 hours even after misoprostol. Consider giving additional dose of misoprostol if it happens. And 75% of women abort within 4 to 6 hours after the misoprostol administration. On third visit, on day 15, what to do? We have to perform a pelvic examination to ensure the completion of abortion. Contraceptive options we have to give, hormonal methods, condoms, IUCD, or sterilization after 1 menstrual cycle. We have to tell the woman about the immediate return of fertility and report back if any cessation of menses or no periods within 6 weeks of completion of abortion process. If we have any suspicion, we can do USG, otherwise it is not routinely recommended. It is done only if we have doubt of incomplete abortion. Side effect and complications of medical methods. First is pain. We have to be respectful, non-judgmental in communication. We should provide verbal support. Adequate counseling should be done. Support person should be there to reassure the woman. And ibuprofen 400 milligram can be given. If there is persistent pain with failure to respond to these drugs for several hours, it warrants evaluation for other causes such as ectopic, pregnancy, infection, or incomplete abortion. Nausea or vomiting, it is self-limiting and we have to reassure. Diarrhea is again self-limiting and we have to reassure the woman. And infection should be confirmed by the signs and symptoms of infection. And we have to start the antibiotic if there is any evidence. Next. Action for failure or incomplete result of medical methods of abortion. If there is failure, we have to offer vacuum aspiration or repeat medical methods of termination. Incomplete result of medical method of abortion. Please mute yourself. Observe unless heavy bleeding is there. If bleeding resolves and uterus return to normal size, means abortion is complete. Or we can repeat the misoprostol dose and it can complete the process, or we can offer the surgical method of evacuation if there is heavy bleeding or there is incomplete abortion. So if excessive bleeding per vagina, the woman presents with excessive bleeding more than her menstrual cycle, soaking 2 pads in 1 hour for 2 consecutive hours. Then if bleeding decreases over the time, then we have to watch vital signs, PV examination for products of conception in cervical canal. Digital evacuation could be done. And if there is decrease in bleeding, then routine care, keep a watch on vitals and bleeding per vagina. She can go home if the bleeding decreases. If it is ongoing, we can do digital examination and evacuation if the products of conception are felt in cervical canal. If woman is stable and bleeding reduces, then we can observe and monitor for vital signs and symptoms for more 1 hour. And if everything is stable, she can go home. Or if the bleeding continues, then ultrasound should be done and minimal residual bleeds, then wait and watch. If product of conception with residual bleeds and woman is stable, misoprostol 600 microgram oral or 400 microgram sublingual can be given. Or if she is not stable, immediate vacuum aspiration can be done. If pregnancy is continued, we have to give surgical option. That is vacuum aspiration of the products of conception. Next. Now, recording and reporting of medical methods of abortion. Since a medical method of abortion comes under purview of MTP Act, the documentation is similar that required for vacuum aspiration procedure. It is mandatory to fill following forms, that is Form C, consent, Form 1, RMP opinion, Form 2, monthly reporting form, to be sent to district authority, and Form 3, admission register for case records. Next. Now, methods of first trimester abortion: surgical, that is manual vacuum aspirator or electrical vacuum aspiration. The surgical abortion methods in first trimester are vacuum aspiration for up to 12 weeks, and WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by sharp curettas. The vacuum aspiration methods, here we can see that this is the cannula and this is the whole MVA with this is syringe, this is collar, and this is the aspirator. So a handheld aspirator used to generate the vacuum, this one, and aspirator is attached to a cannula of 4 to 12 mm. This is here. And cannula can be used in multiple settings using those without electricity. IPAS or easy grip cannula size correspond to weeks of gestation. If she had 8 weeks of gestation, we have to use 8 mm, and for 10 weeks, 10 mm. Next. So electrical vacuum aspirator, here it is machine which is generating the vacuum, and it can accommodate cannula of manual vacuum aspirator with correct size tubing. So what is the role of cervical priming? May be considered for women with a pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. The recommended methods for cervical preparation before surgical abortion in first trimester are oral mifepristone 200 milligram 24 to 48 hours in advance, misoprostol 400 microgram administered sublingually 2 to 3 hours prior to procedure, misoprostol 400 microgram vaginally 3 hours prior to procedure, and laminaria tent placed intracervically 6 to 24 hours prior to procedure, which is a hygroscopic thing, and we have used in our PG days. Nowadays, we are not getting laminaria tent. So pain management plan for vacuum aspirator procedure, important component for quality abortion care. It for reduction of pain and anxiety, which makes the woman comfortable. There are two components, non-pharmacological and pharmacological. Non-pharmacological are providing psychological support, explaining each step to the woman in advance, performing the procedure gently and smoothly, encouraging the woman to relax and breathe deeply. From pharmacological pain management plan includes source of pain and its management. First is out of anxiety. We have to give anxiolytic and GA. Diazepam 10 milligram orally 1 hour prior to procedure, or 2 to 5 milligram IV 20 minutes prior to procedure. The duration of effect is 4 to 6 hours, and side effects are disorientation and dizziness. For the pain out of cervical dilatation is taken care by lignocaine or local anesthesia and analgesics, that is ibuprofen. 10 milliliter or 10 ml of 1% lignocaine should be given and it takes care for 60 to 90 minutes, and 400 to 800 milligram 1 hour prior to the procedure. NSAID or ibuprofen can be given, which takes care for 4 to 6 hours. The side effects are dizziness, seizures, and gastritis. The uterine cramping, the analgesics, ibuprofen can be prescribed in dose 400 to 800 milligram 1 hour prior to the procedure. It takes care for 4 to 6 hours, and the side effect is gastritis. Now, steps of manual vacuum aspiration. So here, how to prepare the instrument. Here we can see that it is bivalve. So close the valve button, and after that, create a vacuum. This is the plunger. We are creating the vacuum. Next is ensure the pain control medication is given at appropriate time, and we have to ask the woman to empty her bladder. Third one, we have to paint the cervix with betadine solution for antiseptic preparation. Next is administration of paracervical block, then dilatation of cervix appropriately, keeping in mind how many weeks of pregnancy is there. If we have to insert the 8 mm cannula, we have to dilate to that size only or a size smaller, and then cannula can be applied. So next one is insert the cannula. Here, after insertion of this cannula, we have to withdraw the cannula 1 to 2 centimeter away from the fundus inside the uterine cavity. So we have not to touch the fundus. We have to be inside the uterine cavity. Then rotate the cannula in 10 to 2 o'clock position with smooth and gentle motion to avoid the blockage of apertures. Now release the vacuum button on the aspirator. So signs that are after doing this process, how we will come to know that uterus is empty? If the red or pink foam without the tissue passing through the cannula. Second is gritty sensation over the surface of the uterus. Cervix is going to grip the cannula and uterus is contracting around the cannula with increased uterine cramping. So next one, we have to inspect the products of conception. Now proceed with contraception methods such as sterilization or IUCD if it is required. And next one is instrument processing. Instrument can be soaked in chlorine solution for disinfection, 0.5% chlorine solution, which helps to remove the tissue and body fluids. Next. Post-procedure care, we have to monitor her for any complication and provide management if required. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that woman has all necessary information and medications prior to leaving the facility. Document all the outcomes of the treatment, including any adverse events, in the facility register and client's record card. Aftercare, the management of abortion complication, that is incomplete abortion, infection, bleeding, ongoing pregnancy, should be taken care accordingly, whatever discussed in previous slides. Provision of contraceptive information and offering the contraceptive counseling and methods should be a must. An assessment of any other sexual and reproductive health needs that may require additional care should also be provided. Follow-up, no routine follow-up is needed unless misoprost alone regime is used. In summary, India has made historic progress in improving access to safe abortion. Not much has changed in technology update in last decade. As providers, it is up to us to ensure safety and quality, especially in context of amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, has an opportunity to inform, educate, and equip with proper information on contraception and counseling. So I request everyone who has been registered for this RAC should give posted feedback, and then they will eligible for getting the certificate. So thank you, Sumandi, for taking pain from my side. And next session is Dr. Atima Bharti. I am inviting Dr. Atima Bharti to take the next session.
Thank you, Kiran. I'll be sharing my screen now.
Okay, Atima, you can share your screen.
Here it's showing host disabled participant screen sharing. Host will have to enable me.
I made you co-host, madam, now. Can you try once, ma'am?
Yeah, can you see my screen?
It is not visible.
Is my screen visible?
No, 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 Dee, not visible.
Not visible.
No.
It's visible now.
It's
It's
visible now.
visible now.
Is it visible?
Yeah,
Yes,
Dee.
it is. Yes, visible now.
So now I'll be talking on module 3, which comprises safe abortion values, evidence, rights, and respect.
Madam, it's not full screen, madam.
Okay. So as all of you all know, this adventure is a joint initiative by Foxy and WHO. And here I'll be talking mainly on what is expected from the, what sort of behavior is expected from the healthcare provider. You have already heard on the techniques and amendment of MPP Act. So this module, this aims to define respectful abortion care according to WHO standards, and it will also highlight how norms and stigma affect abortion care services. There is a short video on it and provide WHO saver resources for RAC. So what is respectful abortion care? It has been adopted from respectful maternity care recommended by WHO. It refers to the care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion, so that any woman she feels safe under your care. In simpler terms, respectful care means that the patient is treated with dignity, empathy, and compassion, regardless of race, ethnicity, gender, socioeconomic status, or reproductive history. We as health providers, we cannot tell them that how many times you are coming for abortion or how many times you are becoming pregnant. Why aren't you using contraceptive? We certainly need to advise them regarding the use of contraceptive. Tell them that abortion is not for family planning. For family planning, they need to use contraceptive. If you ever feel that something isn't right, we need to speak up. As a health professional, it is our duty to listen, at the same time support the women. And to support, communication is the key factor. And to communicate, you need to develop a very good rapport with the patient. So what are norms and stigma? This is a short video on norms and stigma.
Madam, we can't hear the audio, ma'am.
You can't hear the video.
Audio, madam.
Audio. But here, what I need to do then?
Go back, madam. Stop sharing and go back.
Yes.
In the bottom, while sharing, in the bottom left, you'll have two check-ins, madam. Share sound. Hello.
Should I start sharing the screen?
Yes, madam. Before you start sharing the screen, click on
Yeah.
the share button, madam. At the bottom left, you'll find two share two check-in boxes. One is share sound, and other one is optimized for video clip. You have to click on the both the check-ins, then you share, madam.
So share sound.
Click share sound and optimize for video clip. You have to
Okay.
click on the both, then you have to share the video.
Okay, then I'll click on share.
Yes, ma'am.
Okay. Thank you so much.
This is the
social
video.
norms that
No,
are
can you hear?
considered COVID-19 appropriate
Yeah, okay.
behaviors
Can
like
hear.
wearing a mask,
Okay.
maintaining
Thank you.
social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in formal or official conversations or when talking to patients, clients. Now let's look at some girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long term health effects, and the woman's health will never recover to her pre abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. Girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So in the last video, you could see that there should not be any gender discrimination. And these are 7 categories of disrespect and abuse. And stigma and norms, they perpetuate disrespect and abuse, and that needs to be avoided by the healthcare provider. Number 1 is physical abuse in the form of slapping or intimidating physically, verbal abuse like not taking any consent, shouting and screaming at her, sexual abuse in the form of abuse of power and taking advantage, stigma and discrimination. This will be shown in another video. Failure to meet professional standards of care, poor rapport between women and providers, and if the health system condition is not up to the mark and there are certain constraints which makes the women feel uncomfortable in that facility. Now, what are the rights of every woman? Every woman has the right to freedom from harm and ill treatment. She has the right to information. She is protected under the MTP laws and POXO Act. Informed consent and refusal is a right. Respect for choices and preferences, dignity, and quality of care should be up to the standard. Right to timely health care and to the highest attainable level of health. Liberty, autonomy, self-determination, and freedom from coercion are rights of every woman. Now, there are 12 domains of respectful abortion care that has been adopted from respectful maternity care. Number 1 is the women needs to be free from harm and any sort of mistreatment. Her privacy and confidentiality needs to be maintained. Her dignity should be preserved. Her choices should be respected. We should engage in effective communication. These are soft skills which all should acquire. Providing information and seeking informed consent from the women. Ensuring continuous access to support and enhancing the quality of physical environment and resources, providing equitable abortion care. There should be availability of competent and motivated providers, provision of contraception advice and commodity security. And last but not the least, there should be continuity of care and counseling. If even after the abortion, if she needs any care, she should be taken care of. Now, this is the short video on WHO training for safe abortion values, evidence, and right.
How to Talk About Abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is the extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or registered medical practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant, and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So you heard on this video, so how we should be careful while using words. Any words that carry stigma with it should be avoided and should not hurt the sentiments of the women. Now momentum has been created, law has changed, and to disseminate this law needs association of obs and gynae providers. Foxy is the largest provider base for abortion care, and online training was possible due to COVID. Respectful abortion care can reach all the providers through this online training. Medical method of abortion uptake has also increased because it can be used in early gestational age, it is safe, it ensures no PCP and DT conflation. Only thing that matters is patient safety, respect, and quality. And we as health providers have a large role to play. Time has come to strengthen the implementation of the latest law. Important changes for provider opinion. Every patient is an opportunity for respect, and as providers, we have the onus on us to educate them and also to reduce sex-selective abortion. Up to 20 weeks of gestation, by now we have come to know that up to 20 weeks of gestation, one RMP will be required. So one provider will have more responsibility on him or her regarding counseling, contraception, referral, and compassionate care. From 20 to 24 weeks of gestation, 2 RMP will be required. And beyond 24 weeks, opinion of medical board will be required. This law has expanded the eligibility, especially for the young people, for the survivors, rape survivors, for the widow, for the women whose institution of marriage has changed, for unmarried women, and everyone needs unbiased care. So first of all, we as health providers need to overcome our own biases. So all women, up to 20 weeks of gestation, she has a right for respectful abortion care. For 20 to 24 weeks of gestation, there are special categories of women like rape survivors, girls less than 18 years of age, widows, and these women, these category of women, since they are special, they need to be cared with sensitivity, judgment-free, and timely services should be given. If there is any birth defect, then there is no gestational limit, but opinion of the medical board is mandatory. The law which has changed, it prioritizes the confidentiality and safety. All of us know that if we respect others, we will get respect. Respect begets respect. So as providers, we need to be very mindful of all social cultural aspects. We need to be very particular in maintaining the confidentiality of the women who has come to us to seek abortion, except to a person who is authorized in any law for the time being in force. The ground of failure of contraception has also been extended. It is not only for the married women, but it is also for all women and her partner. Respect, quality, and dignity at all types of abortion is required by we health providers. In 1970, it was mostly unsafe abortion. But in 2000, that was changed to safe abortion. In 2020, that has been changed to respectful abortion. So as health providers, we need to be very careful while using our words and while providing abortion services to the women who has come to us to seek abortion. Now, there are certain recap questions. You will get 30 seconds to answer them on your chat box. First question is, according to WHO, restricting access reduces the number of unsafe abortions. True or false? True. This is false. Restricting access will not reduce the number of unsafe abortions. According to WHO definition, safe abortion is when it is done by appropriate method and when it is done by trained person. If either of the criteria is not met, then it will be less safe. And if none of the criteria is met, then it will be unsafe abortion. Whereas if both the criteria are met, then it will be safe abortion. So if you restrict access to abortion, you are not going to reduce the number of unsafe abortion. So number 2 question, the MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parents, guardians, before she can undergo a termination of pregnancy. True or false?
True. True. True.
So again, this is false. Why? Because even if she's less than 18 years, she doesn't need to bring her parent or guardians. Even if her partner who is more than 18 years, he can give a consent. However, POXO reporting is still needed. And you cannot deny abortion services in this case, even if she's less than 18 years. We need to provide bias-free services without being judgmental. Now, next question. 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. True or false? Yes or no? Should you ask the women to continue her pregnancy, or should you provide her with service? Again, the answer is no, because she will come under special category. Here, 2 RMPs will be required. Abortion cannot be denied to any women up to 20 weeks of gestation. And from 20 to 24 weeks of gestation, 2 RMP will be required. And if there is a birth defect, then there is no gestational limit. The only thing is that opinion of the medical board is required. And that comprises a gynecologist, a pediatrician, a sonologist, and any member from the government official. So to end, abortion is, let all of us remember, let all of us understand that abortion is legal in our country. Still, many of the developed countries are struggling to make this law. Let us make this abortion safe and respectful. And to make our country a Samarth Bharat, we need safe abortion made available respectfully throughout health system. Thank you for your patient hearing. You know, Dr. Meenakshi? Dr. Meenakshi?
Good evening, Dee. Good evening,
Yeah.
everyone.
Yeah, you share your slide now.
Yeah.
Now, Dr. Meenakshi will be talking on the contraceptive aspect.
Enable me to share the screen. It is saying that host disable participant screen sharing.
I made you
Can you allow
co-host,
me to
madam. Please
see?
try once.
Now you can share, Meenakshi.
Okay. Is it visible?
Yeah.
Yes, please. Make it full screen.
Yeah, today my talk is on module 3B, where we are discussing about pre and post abortion family planning counseling, as well as leveraging the technology for referrals and online consultation. This is a part of RAC program, which is joined by FOXI and WHO initiative. What is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perception. Pre and post-abortal counseling are important integral part of comprehensive abortion services. It is as important as the procedure itself. Women may need help in decision making. Wherever needed, the spouse should also be counseled. It has a critical role in helping the woman to decide about termination of pregnancy. It helps women to choose the method of termination. It ensures the delivery of complete information about the procedure and help women to adopt a contraceptive method. The procedure is ensure privacy and confidentiality, be non-judgmental and be sensitive, establish rapport, use simple language, and allow the woman to clarify her doubts. And if she has made up her mind for termination of pregnancy, assess her for the procedure. What is relevance? Because there is quick return of fertility, so it is opportune time for contraceptive acceptance. Minimum 6-month gap before next pregnancy causes better health benefit, and better future pregnancy outcomes. 90% of abortion-related maternal mortality can be prevented by ensuring contraception. When it should be started? It is started at the first visit at the time of consultation, exception when there is grief management, then it should be delayed. And what to consent? It is important as the return of fertility within 10 days to 4 weeks, help her with choices, method-specific counseling, and high-risk behavior wherever it is applicable. If woman is not willing for any contraceptive method, do not refuse MTP. Try and counsel her after the procedure. If she is still not willing, call her for follow-up in a week's time and again counsel. Assessing suitability for post-abortal contraception. What are the general guiding rules? First, ensure that abortion process is complete. There is no existing infection, no injury to the genital organs. The chances of fresh pregnancy is ruled out. It has a critical role as it ensures woman has understood precautions and care needed during post-abortion period, and it is also an opportunity to counsel for contraception in case not previously accepted, and reinforces the need for continuing the use of contraceptive method chosen. Post-abortive counseling. Continue to ensure privacy and confidentiality, reassure her in case of any problems, and repeat the information about post-procedure care and the danger signs. If the contraception is already opted, then ensure whether it is appropriate, and in immediate care, IUCD and MTA should be given ongoing, or oral pills should be continued. What are the follow-up protocols and reproductive insurance and cards? And if she is undecided about family planning, then allay her anxiety, importance of immediate adoption and choosing an extended period of adoption, couple counseling, and she should be informed about EC pills also. Post-abortion contraceptive method. The first method is the barrier methods, condoms. They should be started as soon as the sexual activity resumed in both first trimester and second trimester. It has its advantage that there is no hormonal side effect. It can be used without consulting a health provider. It is easily available. It prevents against STIs, including HIV, and enables man to take the responsibility of contraception. Second is IUCD, in which we have property 380 and 375. In first trimester abortion, inserted immediately or up to 12 days after confirmation of completed abortion using the surgical method, with MMA inserted on day 15 of the process, provided complete POC expulsion is confirmed and risk or presence of infection or any other contraindication is ruled out. In second trimester, IUCD can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. Additional information that IUCD is highly effective. It provides long-term contraception for 5 years or 10 years. It can be provided by trained doctors, A&M, nurses after first trimester surgical abortion, by trained doctors only after MMA, and by PP IUCD trained doctors after second trimester abortions. No interference with sex, immediate return to fertility on removal, and it has no hormonal side effect. Now coming to combined oral contraceptives. In first trimester started immediately or up to 7 days after abortion using surgical method. With MMA, it can be started on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of completed abortion. In second trimester, they started immediately or up to 7 days after abortion. It regulates menstrual cycle, can be provided by all health workers after first screening by trained provider, no interference with sex, and offers protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign diseases such as fibrocystic and fibroadenomatosis. Not suitable for women who are breastfeeding babies less than 6 months old. Long-term injectables, MPA, can be injected immediately or up to 7 days after abortion using surgical method. With MMA, it can be started on day 3 with the dose of misoprostol. In second trimester, it can be injected immediately or up to 7 days after abortion. It is also highly effective, confidentiality and privacy maintained, can be provided by doctors, ANMs, nurses after screening by doctors for the first injection. No interference with sex, no effect on the quality and quantity of breast milk, no estrogenic side effect, offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. The permanent method, female sterilization, can be performed after abortion in the absence of any infection or severe blood loss concurrently or up to 7 days. Both mini lap and laparoscopic sterilization can be done. With MMA, it can be done only after the first menstrual cycle resumes. In second trimester, mini lap can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is recommended along with the second trimester abortion. It is a permanent method. It is highly effective and it is effective immediately after. No interference with sex, no effect on breastfeeding, no long-term side effect, and it offers protection against ovarian cancer also. Vasectomy is performed on males independent of timing and procedure of any type of abortion. It is very effective, permanent method, no interference with sex, no long-term health risk. Couple must use another method for 3 months or till the semen test is negative. This is the chart showing the contraceptive methods along with MMA, where we can use COC on the day 3, injectable on day 3, centromen on day 3, COC and IUCD on day 15. This is along with the vacuum aspiration, all the types COC, injectables, centromen, IUCD and tube ligation can be started on the day 1 itself. Coming to the SRS services, teleconsultation and other technology. Leveraging technology, the service provider, there is teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. The technology which is available, that websites are available. Hamdo, social media, there's Ask Tanu and YouTube sites are also available. Infographics, helpline, patient education programs are also available by WHO, Ministry of Health and Family Welfare, as well as RCOGS. SWOT of teleconsultation, which is strength, weakness, opportunity, and threat. The strength that in COVID era it has become very useful. It is approachable throughout the process, confidence in maintained awareness. It spreads out questions answered at each. And weakness is the face-to-face consultation has other advantage. That advantage is here we lack this advantage and we cannot demonstrate as we do in face-to-face. Opportunity, the privacy and comfort is maintained. It is cost saving and it also cuts down the number of visits. And threat is the many things we miss. So misdiagnosis can also be there. What are the applicability of this CAC assessment? We confirm diagnosis, contraceptive needs, counseling, video conferencing or by Zoom, and follow-up. So hybrid services is done 1 visit in and MMA there should be minimum 3 visits. So what are the key messages? Realize the need of post-abortal family planning, bring the couple on board and strive for 100% coverage. Capitalize on basket and applicability in post-abortal period. Technology as far as it is possible, because there's scope for entry in CAC services and concern is the policy, malpractice, service cost and access. Adults and reproductive health needs both online as well as offline. So registration and pre-test, post-test and feedback. So everyone is requested to fill the post-test and then certificate will be provided to participant on attending this. Thank you everyone for patient listening. Thank you.
So this was all about respectful abortion care. And now I would request all the members. So before you leave this session, you click on continue. And when you click on continue, then you will get certain questions. You need to answer those questions, and then you will be registered for the certificate. So don't leave without clicking on continue.
Yes, yes.
Madam,
And
I've shared the RAC post-session feedback link in the chat box, madam. Just click on the link, you will be redirected to post-session feedback. Answer all the questions and you submit, madam. We'll issue the certificate as earliest.
Atima,
Yes, Sumandi.
even we have the certificate, so I think we don't need the faculty.
No, we don't need, but all the members who have participated, who have attended today, they need to get the certificate. So they have to answer those questions again.
Okay, okay. Thank you.
Okay.
So can I leave now?
Yeah, everybody can leave. So thank you all. Thank you, Sumandi. Thank you all participants.
Thank you.
And
Thank you so much.
and thank you supporting technical team.
Yes,
Yes,
ma'am. Please inform the
thank you,
participants to fill the post-session feedback and submit, madam.
Somebody is asking what is continue. So when
They will get the option continue.
Madam,
They can click
sorry
on
to
that,
interrupt
or
you,
they
ma'am.
can go to the link.
Yes, I shared the link, madam. You can click
Or
on the link.
link has been shared by the supporting team, so they can go to that link.
Jai Ho. Hello, Jai Ho.